Hello, I'm Alan So, a urologist from the University of British Columbia, and in this presentation, I'll be discussing the cardiovascular side effects of androgen deprivation therapy used to treat prostate cancer. The objectives of this talk will be to discuss the relationship between androgen deprivation therapy, or ADT, and cardiovascular disease, to determine the effects of even short-term ADT that's often used with radiation therapy, to evaluate the effects of neuroandrogen axis targeted therapies used to treat metastatic castration-resistant prostate cancer on cardiovascular disease, and finally to assess data comparing LHRH agonists and antagonists on cardiovascular disease. Over the last 20 years, there's been a growing interest and research performed on the side effects of androgen deprivation therapy, including cardiovascular disease. As such, there's growing data to show that androgen deprivation or castration may have direct effects on the cardiovascular system, including promotion of atherosclerosis and vasoconstriction of coronary arteries, as well as indirect effects, including cardiometabolic syndrome, obesity, diabetes, and dyslipidemia. However, this data is often fraught with a little bit of controversy, primarily because of the different types of research that has been performed. To summarize, there have been many observational studies looking at very large pool of patients to show a link between ADT and CVD. The advantages of this is obviously the large number of patients, as well as the ability to show links of various different subcategories of CVD. The disadvantages, however, are the presence of known and even unknown confounders, as well as selection bias. Another set of data comes from a post hoc analysis of the combination of various randomized controlled trials. Now, these trials didn't inherently look at the side effects of ADT, but cardiovascular mortality and cardiovascular disease associated with or without androgen deprivation therapy has been looked at. The advantage of this data set is that it's often considered cleaner. The disadvantage is that it's still a post hoc analysis without often pre-specified intent of the analysis of androgen deprivation therapy side effects, and thus does not remove confounders or selection bias. Hence, there's no perfect data set out there to prove either the direct correlation or lack of correlation. However, there does appear to be growing evidence of the link between ADT and cardiovascular disease. One important aspect that we must remember when we're looking at any of this data is the fact that cardiovascular disease represents the most common comorbidity and cause of death amongst men with prostate cancer. In this study, looking at the SEER database, it shows that men with clinically localized prostate cancer are actually more likely to die from cardiovascular disease than prostate cancer itself, or even any other type of diseases or cancers. This emphasizes the fact that cardiovascular disease is very important in men with prostate cancer, and as well is very important as men age, as prostate cancer is a disease of older men. In another observational study, looking at the impact of androgen deprivation therapy and different types of cardiac morbidity and mortality, shows that regardless of the method of androgen deprivation, any type of castration is associated with increased risk of coronary artery disease, MI, sudden cardiac death, and stroke. Interestingly, the subpopulation of men with the highest risk of these different problems are those with bilateral orchiectomy, suggesting that men who have the longest time of androgen deprivation therapy may be at greatest risk. In another large observational study, looking at men in a cancer registry, those men that were treated with androgen deprivation therapy when compared to those men who were not had an increased risk of 30% of cardiovascular events. Interestingly, meta-analyses of various different randomized controlled trials utilizing androgen deprivation therapy does not clearly establish a link between androgen deprivation therapy and cardiovascular risk. Interestingly, these RCTs were not designed with cardiovascular events as a primary outcome measure, and thus would likely be underpowered to detect a difference given the low event rates. It is also important to note that the RCT data does not stratify results based on cardiovascular disease history in individual patients, and therefore the conclusions need to be interpreted with caution. There is growing evidence, however, that those that are most influenced by androgen deprivation therapy to have detrimental cardiovascular effects are those men with cardiovascular disease. In this slide, there are 4 studies showing the clear link between cardiovascular mortality or cardiovascular event with a history of cardiovascular disease in those men who received androgen deprivation therapy. Even a short duration of androgen deprivation therapy may affect those with a history of cardiovascular disease. In this multicenter study of over 5,000 men who had undergone brachytherapy and received neoadjuvant androgen deprivation therapy, those that had a previous history of either CHF, congestive heart failure, or prior myocardial infarction had a significant increased risk of cardiac specific mortality than those who did not receive androgen deprivation therapy. In this study, men received a median of only 4 months of androgen deprivation therapy, and this correlated with an increased risk of 5% of cardiac specific mortality in those with a history of CHF or MI. This again points to the importance of identifying those men with risk factors, even undergoing a small amount of androgen deprivation therapy. This effect can be even very long term. And in this study of over 2,000 men, those men who received ADT with radiation had a 10-year incidence of cardiac events that was much greater than those who did not. Now, this effect thus can last over 5-10 years, and as you can see in the graph on the left, this tended to increase with time. And in fact, using a multivariable analysis, previous cardiac event prior to radiation therapy was the strongest risk factor for a new onset cardiovascular event in those men who received ADT. Fortunately, there's ongoing research looking into the relationship between androgen deprivation therapy and cardiovascular risk. This study, called Radical PC, led by Drs. Dale Young and Yoni Pintus in Canada, is one of those studies trying to determine whether or not cardiovascular risk either can affect physicians' decision to use androgen deprivation therapy, or whether or not a lifestyle intervention or cardiovascular risk intervention can help reduce future cardiac events in those who received angiogen deprivation therapy. Radical PC1 is an observational study, again, looking to see whether or not physicians alter decision making based on cardiovascular risk. Whereas Radical PC2 is a randomized study to determine whether or not modifying cardiovascular and lifestyle risk factors can ultimately change future cardiovascular events. I think this is a very exciting study that will hopefully bring us more information in terms of that risk between and relationship between angiogen deprivation therapy and cardiovascular events. The impact of ADT on cardiovascular health is especially important with the increased use of novel agents that target the androgen receptor axis. As you can see in this slide, androgen deprivation therapy remains the cornerstone of all advanced prostate cancer treatment, whether it's metastatic castration-sensitive disease, non-metastatic castration-resistant disease, or metastatic castration-resistant prostate cancer. As well, when you consider that this is often combined with novel agents that can significantly further inhibit the androgen receptor axis pathway, including drugs such as enzalutamide, abiraterone, apalutamide, and darolutamide, the impact of cardiovascular health must be further understood, especially considering data that is now coming out showing that there is growing cardiovascular toxicity associated with the combination therapy of these agents. One of these studies utilized a meta-analysis to look at abiraterone and enzalutamide in various different randomized controlled trials and the associated additional risk of cardiovascular comorbidities. In the top forest plot, you can see that the addition of abiraterone or enzalutamide increased all-grade cardiovascular adverse events. And this was even further emphasized in the lower forest plot, which showed an even greater increase of grade 3 or more adverse events in those who received these agents. Now, obviously, this is an outcome that was not pre-specified in these studies, but does show some type of signal in the fact that there could be an increased risk of cardiovascular comorbidities in these agents. In another study looking at abiraterone and enzalutamide and short-term mortality after initiation, you can see that the pre-existing effect of having cardiovascular risk factors such as atrial fibrillation, CHF, stroke, or ischemic heart disease prior to the initiation of either abiraterone or enzalutamide significantly increase the risk of short-term mortality. And this increased with more risk factors that you had. When we look at non-metastatic CRPC, we also see that even with a short duration of follow-up, a median of less than 24 months, we do see a signal of an increased risk of cardiovascular side effects, whether it's hypertension, MACE, coronary artery disease, or CHF, in receiving either enzalutamide, apalutamide, or darolutamide in non-metastatic CRPC. And this is interesting because these are men that potentially could be on these therapies for many, many years. And I think for sure we will need to look at further research as to, first of all, whether there truly is a link between these agents and ADT with cardiovascular disease, but as well, what type of things that we can do, whether it's lifestyle modification, cardiovascular risk factor modification, etc., to try to reduce this risk. In the final part of my presentation, I want to look at some of the data comparing LHRH antagonists and LHRH agonists on CV mortality and CV risk factors. In this recent meta-analysis looking at various different studies of LHRH antagonists and LHRH agonists, there does appear to be a benefit of an antagonist compared to an agonist on cardiovascular mortality. The potential differences of an agonist and an antagonist were also seen in a randomized control study looking at the oral LHRH antagonist relugolix compared to the LHRH agonist leuprolide acetate. And in this study, looking at 930 men that were randomized to receive either relugolix or leuprolide injection every 3 months, there appeared to be a reduction of the incidence of MACE in those that received relugolix compared to those that received leuprolide acetate. The interesting thing to note here, though, is that this absolute difference is still obviously quite small, even though there is a hazard ratio of 0.46. One of the more interesting aspects of this data, however, is when you look more closely into the risk of development of a CV adverse event with those that had a history of a previous cardiovascular event, or otherwise known as a MACE event. And when we look at this data, there doesn't appear to be a difference between the LHRH agonist and antagonist in those without a history of MACE. However, those with a history of MACE did appear to have a difference in outcomes, as shown in the bottom right. Again, there is a difference, but this still has a very small absolute difference, primarily due to the low number of events. Thus, there are limitations of this study. The study was unblinded. Cardiovascular events were not primary endpoints, and the absolute differences were actually quite small. As well, the trial lacked a true endpoint adjudication committee for cardiovascular events. There are also some issues in identification of MACE. The FDA also recently stated that the HERE study did not demonstrate an improved cardiac safety profile compared to leuprolide. However, the cardiac safety was acceptable for the indicated population. So although there does appear to be a signal, there still is not a clear, true data to show that there is an advantage of using an antagonist versus an agonist with the HERO trial. There are ongoing studies, including PRONOUNCE, to further look at the differences between LHRH antagonists and agonists. And this study, which is recently closed, is looking at the risk of cardiovascular disease in those patients with a previous history of MACE and those that are receiving the GnRH compared to those that are receiving leuprolide acetate. And again, the primary objective is to look at the occurrence of MACE effects in those patients with a history of cardiovascular disease. It's a very large study and recently closed. It's randomized, and hopefully this will provide further insight as to the differences between the GnRH agonists and antagonists and cardiovascular risk. In summary, although there is some controversy, there is growing evidence of both direct and indirect effects of ADT in cardiac health. Men with previous cardiovascular history are at greatest risk. This will be more important, especially with earlier and longer use of AR axis targeted therapies. Future results from current trials will assess the impact of exercise and lifestyle on the mitigation of these risks, as well as potential differences between LHRH antagonists and agonists on cardiac health. Thank you.